So good morning, everybody. Today I'll be presenting short and long-term treatment outcomes for thermal and non-thermal technologies used to treat vein disease. This is the outline of my presentation today. Basically, the thermal technology we'll be reviewing is RF and laser ablation. The non-thermal technologies include Cyanoacrylate, VENASEAL, mechanical occlusion, chemically assisted ablation, and varicose. I'll be talking about outcomes in terms of closure rates and recurrence, patient physician reported clinical outcomes, complications, ultrasound morphology, hemodynamics as well. Outcome terms, when I mention immediate outcomes, I'm referring to the first 30 days after the procedure. Short-term outcomes usually refer to a few months till a few years after the procedure, and long-term outcomes refer to 5 years up to 8 years and beyond. So as a historical background review here, for a century, surgery has been the golden standard for treating saphenous vein disease. The idea of ligation was introduced really in the 800s, but it wasn't until Trendelenburg who introduced that into practice. And a few years later, Keller described the first internal stripper. And for 100 years, ligation as stripping has been performed usually in hospitals.
He's literally inside.
Usually done under general anesthesia. And after the procedure, patient will have to miss work for a couple of days or up to a few weeks if he's doing some kind of heavy work. It's rarely done nowadays. However, still a few considerations or indications where surgery can be done, including the presence of aneurysmal vein segment near the junction or symptomatic arteriovenous fistula, where patient presents with heart failure symptoms, shortness of breath, and massive edema. Surgery wasn't a completely safe procedure. It had its complications. Wound infection happened up to 4% of patients, usually more in smokers and obese. Nerve damage occurred up to 40%.
But I never use it anymore.
Damage has been reported. Injury to the femoral vein or femoral artery was very rare, but if it happened, can be catastrophic and could lead to loss of the limb. Recurrence after surgery has been studied and reported in many studies and average around 50% in 5 years, and according to some studies, up to 75% in 10 years. And this is not just because of failure of the procedure, it simply reflects the chronic nature of the disease. So researchers began working on ablation, radiofrequency ablation in the early 60s. And there has been a lot of experiments, but a lot of failures as well. So the technology has went through a lot of improvements in terms of improving the current and adopting better algorithms to improve the way the device measures or samples the temperature and impedance at the wall. And basically, there were two concepts or two primary catheters that were suggested to be used: the closure catheter and the restore catheter.
You know all about what I do.
Catheter was supposed to.
Can you hold on a second, Mohamed?
Yes, sir.
Can you hold on a second? Ladies and gentlemen, can you please mute your microphones? This is a chronic, ongoing problem every Friday. All right, and it's really rude to the speaker. So whoever's dog is barking in the background, please mute your microphones. Please. Thank you. Go ahead, Mohamed.
Thank you. So there were two primary models, the restore catheter and the closure catheter. And the idea behind the restore catheter was to use it in order to perform ablation below the valves, hoping that will restore competence to the valves. And the closure catheter was supposed to be used to ablate the whole vein. So they did a study in the year 2000 where they randomized 210 patients into two groups. One underwent ablation with the restore catheter, but that was a failure. Only 60% of limbs had improvement in their reflux by ultrasound and symptoms. However, the closure catheter was very successful. At 6 months, 93% of the veins were occluded and 96% of patients were symptom-free. So the closure catheter was adopted into commercial use and was first FDA approved at 99. The first catheter was based on a pullback mechanism, like laser today, where the temperature at the tip would be 85 Celsius, and the energy or the dose of the energy delivered depended on the speed. And there were some challenges with that first generation catheter. First of all, the slow treatment time. It took up to half an hour to treat a long GSV segment. There were also problems with the device, with the catheter contact with the vein wall. It was poor contact. That's in some occasions, and that led to frequent device shutdowns. So in the year 2007, the second generation, the one we use right now, the closure fast segmental catheter has been introduced. The temperature at the tip of the catheter reaches 110, and it's based on segmental pullback, so no need for continuous pullback. However, with the second generation catheter, there is an element of forward heating. That's why placing the tip of the catheter 3 centimeters from the junction is very important. It is important to follow proper technique with RF ablation to guarantee good outcomes. And this includes exerting external compression with ultrasound probe to maximize contact between the vein wall and the catheter. Also, giving adequate tumescent anesthesia, which will compress the vein wall, provide comfort to the patient, and limit heat injury to the surrounding structures, specifically nerves. Looking at the efficacy of short-term efficacy of radiofrequency ablations, there have been a lot of observational studies and randomized control trials that have proven very high efficacy, up to above 90% for RF. I summarized some of those key trials in the table on the right. In the Evolve-1 study, which was published in 2003, that was a multi-center study, and they looked at the primary closure rate at 4 months, which was 90.5%. It's interesting to note that 10% of veins were open at 4 months, but most of those patients were asymptomatic. The follow-up from that study, which was the Evolve-2, was published 2 years later, 2005. 45 patients were followed for 2 years, and the closure rates at the end of those 2 years were found to be at least equal to surgery. Out of the veins occluded, 50% were shrunken and 40% were not seen anymore. And the recurrence of varicose veins at the end of 2 years was equal between the surgical and the RF group. In the year 2000, Ilkafas did another study where he randomized 180 patients into 2 groups, 90 patients in each one, and followed them for 2 years. And basically, the primary closure rate at the end of year 2 was 94% for the RF group. There were no difference in recurrence rate between the RF and the surgical group. It's important to know that most of those studies were done with the first generation catheter. So the results should be even better with the second generation catheter, the one we use right now. In order to look at long-term efficacy or closure rates, Dr. Merchant and Pichot and their team did a prospective study in a multi-center setting where they looked at 117 limbs. They actually started with looking at 1,200 limbs, but ended up at the end by the end of 5 years with only 117 limbs. So there was a little bit of poor follow-up during the study. Nevertheless, they looked at the post-ablation success rate, and that was 87.2 at the end of 5 years, with 83.8 veins with absence of reflux. An important observation from that study is that most of the veins that had anatomical failure, 70%, almost 70% of them were occluded initially, then partially or completely recanalized. And it's important to, an important observation from that paper as well is that the majority of the patients who had anatomical failure were asymptomatic in the first few years. Those findings were confirmed by another European long-term study that looks at RF outcomes done in a multi-center setting. They looked at 295 GSVs treated by RFA. That study had good design, and there was 80% compliance, which is very good with the follow-up period. The results showed an occlusion rate of 94.9%. When I talk about radiofrequency long-term effects, it's important to mention recurrence. And this has been studied in length in regards to recurrence after surgery, stripping and ligation. There are fewer papers, however, that focus on recurrence after thermal ablation. But we know, based on our experience with the recurrence after surgery, that recurrence happens. It's just it's a reflection of the chronic nature of the disease, and has been estimated to be around 50% in 10 years. It is important to recognize that the cause of recurrence after surgery, or the most common cause, is new vascularization, and that's because surgical intervention in the groin area can interrupt normal physiological flow, which will lead to activation of angiogenic factors, and that will lead to new vascularization. Where in endovenous thermal ablation, the most frequent cause of recurrence would be recanalization, followed by the presence of incompetent accessory vein, followed by the presence of perforators. So in the year 2000, Dr. Pennon led a consensus conference that provided a standard definition of recurrence of vein disease after surgery. And the definition was the existence of varicose veins in the lower extremity previously operated on for varicosities with or without adjunctive therapies, which included the true recurrences, residual veins, and new varices. They subclassified that into anatomical or ultrasound recurrences, which frequently were asymptomatic, and clinical recurrences. And this form of REVAS was suggested to be used by clinicians and also by those involved in research. And the goal was to make future research comparison between trials more easier. In a meta-analysis published or done by Dr. Thomas O'Donnell and published in 2019, the author looked at around 8 randomized control trials that were published at 2000 and 2014. And they were looking primarily at the recurrence rate. They included those studies because they had a minimum of 2 years of follow-up. 3 of the 8 focused on RF, and 5 of the 8 studies focused on laser. And basically, based on their analysis, there was no difference in clinical recurrence between the RF group and the surgical group at the end of 2 years. There was also one important observation was an increase in the recurrence rates in both the RF group and the surgical group that happens as time passes. It increases over time. So what about the ultrasound morphology? What do we expect after RF ablation? The immediate effect after an RF ablation would be vein spasm, which is caused by the contraction of the collagen. The coagulation process in the vein starts almost immediately within few seconds, and you expect to see acoustically heterogeneous echo in the lumen. If you look with ultrasound after a week, the vein will be uncompressible with thick walls, and you can see echogenic cord-like appearance, as we see in the picture on the right here. Dr. Pichot and his team tried to look at the process of the evolution of the GSV trunk itself after RF ablation. And they looked at a sample of 18 limbs, and they used a T-score ultrasound terminology to make a description of findings easier. T0 refers to a vein that's not seen anymore. T1 means hyperechogenic. T2 refers to hypoechogenic vein, and it's subclassified according to its compressibility. So they looked at 1 week, and they looked again at 6 months after the procedure. And looking at 1 week, most of the veins or 60% of the veins were T2 or hypoechogenic, which refers that the lumen of the vein was going some kind of inflammatory process that was transforming the morphology of the vein. And 40% of the veins were hyperechogenic. The authors concluded that this transformation process will take at least 6 months. And they looked again at 6 months. And at that point, 7% or 7 GSVs were not seen anymore. 10 GSVs were shrunken or obliterated with a T1 look. 1 vein showed signs of segmental recanalization at 6 weeks and remained stable till 6 months. And they concluded that the segmental recanalization one of three outcomes. It either stays stable, it either thromboses and closes, or advances into complete recanalization. Those findings were confirmed by other studies, including another cohort of patients, which was studied by the same author, and where he noticed that after 2 years, 86% of limbs showed absence or disappearance of the veins. Now, what about the change in morphology of the junction itself after RF ablation? This can be classified into three categories. J1 refers to complete obliteration of the junction. J3, where the junction is open and there is a terminal GSV incompetence restored. And J2 refers to the presence of flow of tributaries into the junction, into the deep vein. And this can be subclassified into J2A, where there is no stump, the vein is closed, the stump is closed, or J2B, where there's a small open stump. And when Pichot looked with the ultrasound at 1 week, there was equal distribution of when looking at the outcome of the junction, the veins were equally distributed between G1, G2A, and G2B. However, looking with the ultrasound at 6 months, most of the veins were at G2, meaning most of the veins have some kind of flow from the tributaries through the deep vein through either open or closed stump. Another study was done where they looked at a cohort of 63 limbs and followed for 2 years, and it was done by the same researcher team, and they found that the most common outcome was actually J2B. In 82% of the patients, where there is some kind of tributary flow through a small, less than 5 centimeter stump. One important observation is that GSV ablation usually will restore the terminal valve competence, and that's through a reduced blood flow and a reduction of the diameter of the junction. So, does the presence of this short patent SFJ stump has any clinical effects? Well, the short answer is that is unlikely. However, to study that, Merchant and his team conducted a study where they looked at 121 patients at the end of 2 years. For 2 years, they started with 319 patients, but they were poor follow-up. And they were primarily looking as a primary endpoint at the status of vein occlusion. And they subdivided their patients into a complete occlusion group and non-complete occlusion group, referring to the morphology of the SFJ by ultrasound. And they basically found no difference in terms of clinical symptoms, pain, fatigue, edema, or pigmentation between the two groups. This study, however, was limited given the fact that the second group here, the non-complete occlusion group, which is the most important group, it's the one we're studying, was actually a very small 5 patients only by the end of 2 years. So it made any statistical finding questionable. Anatomical failure is a term which refers to failure of the vein to occlude after ablation, and usually can be divided into 3 types, or there are 3 types of that. The type 1, which is the non-occlusive and refers to and usually happens when the operator fails to deliver the sufficient dose of energy required to close the vein, or if the collagen contained in the vein wall is very resistant to heat due to genetic factors. And this is based on theory. It hasn't been the collagen theory. This is a theory, hasn't been proven by research. And type number 2 is due to recanalization. And this is the most common cause of anatomical failures, up to 70%. And usually it's associated with incompetent thigh, tributary, or perforator. Type 3 refers to the presence of groin reflux associated with incompetent accessory veins. And it's usually a reflection of the chronic nature of the disease. In Pichot long-term study that I mentioned in the previous slide, he noticed that many patients, if not most patients with anatomical failures, reported some kind of clinical improvement. And when he did his statistical analysis, he noticed that mainly type 2 and type 3 were more likely to develop recurrent varicose veins in the following 5 years. Those findings were confirmed by a recent study by Avian and Banel in 2014, who looked at 249 limbs in a multi-center setting, and also found out that anatomical failures are associated with twofold increase in symptomatic recurrence in the long term. There were no risk factors identified. When it comes to quality of life outcomes, most studies have shown RF to be superior to surgery in the immediate post-op term, up to 2 years, in regards to less pain and faster recovery. RF ablation is even better, a little bit better than laser in the immediate post-op period, the first 2 to 3 weeks. However, after a month from the procedure and going forward in time, RF and laser are very comparable in outcomes. I summarize some of the key studies here that focused on patient and physician-reported outcomes. In Rocio 2002 study, RF was found to be associated with less post-operative pain compared to surgery. There was less need to analgesia and less sick leave need. In the Evolve 1 study, there was less pain with RF and earlier return to work and better cosmetic results. And in the follow-up from that, the Evolve 2 study, it basically confirms the significant advantage of RF over surgery. There were better quality of life scores at 1 year and 2 years. However, both the RF and the surgery group showed similar CEP and VSS scores at 1 and 2 years. The recovery trial, which compared RF with laser, showed that laser was superior, showed that RF was superior to laser in the only within the first 30 days in terms of a little bit better CIVIC-2 scores and better VSS scores. What about complications? Well, complications are less with the second generation, the one we use right now, RF catheters. They're usually below 2% and usually are mild. One of the most common mild ones is superficial venous thrombophlebitis, as we see here in the picture. Usually presents with tenderness, redness, discomfort, usually is self-limited and results from trapped blood in the vein segments and response to symptomatic treatment. Burns are very rare since the introduction of tumescent anesthesia. Bruises are less frequent in RF compared to surgery. In the recovery trial, which compared RF with laser, 51% of the laser group actually has some kind of moderate to severe ecchymosis, where in the RF group, only 2.2% have some kind of had moderate to severe bruises. Bleeding is a very minor risk, even in patients who are taking anticoagulation, and is usually self-limiting. In a study published in 2010 by Sharifi and his group, he looked at patients who all went through thermal RF ablation. Half of them, or one group, was taking anticoagulation and the other group was not. And he looked at the major bleeding risk in the peri-procedural period, and there was no differences at all. The only difference was found in the subcategory of patients who were taking triple therapy of warfarin, aspirin, and Plavix. There was a minor increase in the minor bleeding risk. That study was limited by its small size, though. Another complication that might happen is numbness and damage to the nerve. This has been around 1 to 3.4 based on the most recent studies or data. This happens because the GSV runs very close to the saphenous vein in the below knee area, and the SSV is very close to the sural nerve in the below knee, in the cuff area as well, especially if the SSV runs a little bit laterally. There's also a risk of damage to the tibial nerves around the popliteal area. Given tumescent anesthesia, it is important to limit that risk. It's important to notice that anesthesia or numbness or nerve damage, when it happens, usually most of those cases will subside and resolve over time, but not all of them. Some patients, unfortunately, will end up with permanent damage. DVT is less common compared to surgery. With surgery, the risk was up to 5.3%. However, with RFA, the risk is around 1% with the second new generation RF catheters. Positioning the tip 3 centimeters over the junction is crucial to limit that risk. Early emboliation is recommended as well. Endothermal heat-induced thrombosis is a complication that happens and refers to the vein closing a little bit higher than supposed to, and advancing into the deep vein. It can be classified into 4 classes, and according to those classes, the decision to start anticoagulation or not can be made. The risk of EHIT, based on the most current data, is around 0 to 4%. And there have been few studies trying to identify risk factors that can predispose to EHIT. And some of those suggested risk factors are male, gender, history of DVT, prior TVTs, big veins with diameter above 8 millimeters. But it seems that the most important one is distance from the junction. Other rare complications include cellulitis, which is very rare, and secondary lymphedema, which can happen if the patient had multiple surgical intervention at the groin area. The second thermal technology that's most commonly used is laser, and this has been FDA approved in 2002. Laser comes, there's a little bit of variety in the technology itself in terms of wavelength, and this is very important to recognize because it can affect our outcomes. Laser comes in a wavelength range from 808 to 1920. The shorter wavelength target the oxyhemoglobin or hemoglobin molecule as a chromophore, where the higher wavelength laser will target water in the interstitial tissue in the vein wall. To ablate the vein, it is required to deliver sufficient dose of energy. However, on the other side, too much energy can lead to more pain and bruising after the treatment. And that was the main challenge in the earlier years of using laser. A lot of patients reported having pain after the procedure, and almost 50% of them needed some kind of analgesia. So there was a focus on improving the technology itself. And one of the things they looked at is the wavelength of laser. There have been multiple studies. I summarized some of those key studies on the right that have shown that the use of water-based longer wavelength is better in terms of less pain and less bruising. It leads to less perforation, micro perforations in the vein wall, so less extravasation of blood into the interstitial tissue and less pain in the post-op procedure. In a study done published in the year 2016, Kapnick and Sadek did a comparison. They divided the cohort of patients in 3 groups treated by 3 lasers of 3 different wavelengths. And they also used 2 types of laser fibers, bare fibers and covered jet fibers. And their results showed clearly that the longer wavelength laser has better outcomes in terms of less pain and bruising after the procedure. Also, the cover type laser they proved that it's much better than the bare type laser. One important finding or observation from that study was that the type of the laser fiber you use is a more important factor than the wavelength of the laser itself. Another important concept is the amount of power sitting when the laser machine when you do the laser. It has been suggested that using less power, like 5 watt, is better in terms of less complications after the procedure compared to using a higher setting of 8 watts at the same wavelength. The dose of energy delivered can be controlled by the pullback speed, and the recommended speed is 1 to 3 millimeter per second. And the dose of energy itself can be measured or compared using 2 main concepts: lead, which refers to linear energy and is measured in joule per centimeter, and the recommended dose is 40 to 60 for high wavelength lasers like the one we use in Center for Vein Restoration. And the new concept of EFE, which refers to endovenous fluence equivalent, and that usually is measured in terms of joules per square centimeter or area of the vein wall. This is supposed to be a more accurate way of measuring the energy dose, and the standard recommended dose is 52 joule per square centimeter. Anything above that might be associated with complications in terms of more discomfort and bruising for the pain after the procedure. So how does laser work? Well, there are 2 theories, and those theories are based on older studies that were done basically on hemoglobin lower wave length lasers. The first one, which is the steam bubble formation, suggests that laser energy will lead to blood water evaporation, which along with the transmitted heat will lead to endothelial damage and the beginning of thrombotic cascade that will lead to thrombotic occlusion of the vein. Inflammatory cells will also infiltrate into the deeper layers and lead to fibrosis and occlusion of the vein. On the other hand, supporters of the photothermolytic energy suggest that laser energy at the tip, or the contact point at the tip of the laser with the vein wall, this energy will actually go through all layers of the vein wall, will induce injury and cause numerous micro perforations and carbonizations, which will eventually lead to fibrosis and closure of the vein. Looking at the short-term efficacy of laser, there have been numerous observational studies published within the last 15 years, all proven efficacy rate of at the short term of 90% and above. Most of those observational studies included small to medium number of patients, 40 up to 1,000 patients. They all, or most of them, focused on GSVs, and the follow-up ranged from 3 months up to 3 years. And the complication rate was usually below 2%, and most of the complications were minor. This was confirmed by a few randomized trials comparing laser to surgery. So in order to find out the long-term efficacy rate, Myers and his team published a study in the year 2008, where they looked at 509 veins treated with 810 nanometer laser and follow them for 5 years. So the primary closure rate by ultrasound at the end of 4 years was 75.7%. And when they combined that, when they used USG or foam, one session of foam for the veins that didn't close initially, the secondary ultrasound success, or what they call assistant success rate, jumped to 97.2%. At the end of 4 years. And this supports the idea of using foam or phlebectomy in addition to laser in a comprehensive treatment plan to eradicate the venous hypertension, and the success of that policy. Those findings were confirmed by Rasmussen in a paper published 2013, where he looked at 137 limbs and divided those into 2 groups, one treated with surgery and one with laser. And he followed those periodically for 3, then 6 months, and then yearly up to 5 years. And he basically found that there was no difference at the primary closure rate between comparing laser to the surgical group at the end of 5 years. There was no difference in clinical recurrence as well. When it comes to patient-physician reported outcome measures at the long term, Rasmussen has proven in his paper that outcomes of laser is comparable to surgery. As I mentioned, laser might be associated with a little bit more post-op pain and bruising compared to RF, mainly at the first 2 to 3 weeks. But nowadays, with the adoption of long wave length laser and the adoption of use of cover type laser, there is basically no difference between RF and laser. Complications of laser can be divided into intraoperative challenges, which include difficulty advancing the laser, transient heat, and nerve pain, and complications that can happen after the procedure itself. And most of those are identical to RF, and I have covered those in a previous slide. In a study published 2013, meta-analysis was conducted by Megan Dermody, trying to look at the complication rate of RF within a year of the procedure, and she included randomized control trials that were looking at our laser, RF, and surgery. She excluded any trials that included foam or had any redo GS procedures, and 2,624 limbs were looked at or included in this meta-analysis. And the findings suggested that the results from that analysis showed that surgery was associated with high wound infection compared to endovascular ablation, and had a lower risk of thrombophlebitis compared to laser with very robust p-value. On the other hand, laser has less risk for numbness or nerve damage compared to RF and surgery with a strong p-value, and there was no difference in skin burn risks between laser and RF. Now, moving into non-thermal technologies, the first of those is varithena. Now, the use of foam has been done or used for many years. The problem with foam that the quality of foam used depends on its characteristics. It depends on the air-gas ratio, on the mode of preparation, on the quality of the bubbles, the distribution of the bubbles, and the elimination half-time. So varithena came out and was approved in 2013, and the goal was to provide very high quality foam. Varithena is a proprietary canister that delivers low nitrogen, 0.8%, which is another important thing because nitrogen might be linked to neurological high level of nitrogen and can be linked to neurological side effects. So this one has the advantage of very low nitrogen concentration, 0.8%. Which produced microfoam so varithena produced microfoam with consistent physical characteristics. And the first pioneer studies that were conducted about varithena were the VANISH-1 and the VANISH-2 studies. The VANISH-1 was a randomized multi-center blinded study where they looked at 279 patients up to 8 weeks. So it was a short-term study. And what's interesting about this one is that the primary endpoint was the quality of life, patient-reported and physician-reported quality of life and safety of the medication. And that was based on the request of the FDA. So they randomized the patients to two groups. One received varithena and another was a placebo group. And basically, what that study showed that there was significant improvement in the quality of life scores in the pooled patient group with a very robust p-value. One of the secondary endpoints was the vein closure rate, and that was found to be 80.4%. Most complications were mild, around 10% though of the patient had some kind of thrombotic adverse event. 221 of the VANISH-1 studies were followed up to a year after that, and the results was published as the VANISH-2 studies. And the results confirmed what we knew from the first study. There was continuous meaningful improvement in all the patient-reported and physician-reported outcome scores. When they looked at the ultrasound outcomes in terms of vein closure by the end of the year, 73% of patients showed ultrasound response. However, what's interesting is the symptoms improved whether the patient was an ultrasound responder or not an ultrasound responder. As we see here in the graph, both groups, though the first one with marked response to varithena with closure on the ultrasound has significant improvement in their quality of life scores, which matches the non-responders at the end of 1 year. The most common complication was retained blood, leg pain, and superficial thrombophlebitis. So the VANISH studies had a primary endpoint of quality of life, quality of life outcome and patient safety. So in order to design a study looking at vein closure as a primary endpoint, Pamela Kem conducted her study and published her results at 2020. It was a prospective observational multi-center study, and basically she looked at 60 patients with reflecting GSVs, accessory veins, and SSVs, which is something different from the VANISH study because the VANISH study did not include SSVs. And she treated them with varithena and followed them for up to 6 months. And she was looking at primary closure rate, which was around 93% at 6 months, which is great. She also shown in her results marked improvement in the VSS score, which dropped to 1.4 from 7.3 prior to the procedure. She had, when it comes to complications, 8% had some kind of thrombophlebitis, and only one patient had DVT. That study was limited because there was no control group, and most of the patients were C2 or C3. Few patients had advanced disease C5 or C6. So one concern with foam and varithena is the risk of the foam going deeper through perforators and giving you a DVT. The risk or the adverse thrombotic events reported at the VANISH study was 10%. The CHEM study, which I just reviewed in the previous slide, was 1.7%, quite a drop. And CHEM and her team argued that the adoption of adjunctive techniques has contributed to the drop of the incidence of thrombotic events. Those suggested adjunctive techniques, including limiting the volume of foam used, using limb elevation, using ultrasound probe to compress the vein, and foot dorsiflexion. So in another study, which was just published this year by Juan Jimenez, Dr. Jimenez tried to investigate whether those adjunctive techniques would really limit the risk of DVT. So looked at 157 limbs for up to 3 months after using varithena, and he used those adjunctive techniques on all the patient procedures. And the reported incidence of adverse thrombotic events was around 3%. And early closure rate, which is another interesting finding, was also excellent, 95%. One limitation from that study was the lack of long-term ultrasound follow-up. They only looked with ultrasound at 48 hours after the procedure, so most likely they missed a number of asymptomatic DVTs. So key points with varithena. Varithena is ideal for veins with tortuosity. Varithena can be safely used with laser and RF, and varithena is the only modality that can be used to treat axial vein and tributaries in the same setting. The second non-thermal technology, which is VENASEAL or Cyanoacrylate, this was approved 2015 by FDA. Again, it has the advantage of being non-thermal, so less risk of nerve damage, no tumescent anesthesia is used. This is marketed as VENASEAL by Medtronic in USA, and they use the N-butyl 2 cyanoacrylate form. The first published data dates back 2013 by Almeida, who looked at 38 patients treated with VENASEAL and followed them for a year. There have been, he reported very good results with 92% primary occlusion rate at 1 year, and quite improvement in the VS score with a robust p-value. He placed the catheter at a distance less than 5 centimeters from the junction and ended up with glue extension happening in 21% of the patients, all resolved within 6 months with no anticoagulation. The second trial, which was a European one, published 2015, the ESCOPE trial, 70 patients were followed for a year, and the primary occlusion rate again was above 92%. The catheter at this trial was placed at 5 centimeters from the junction, and there was only one patient who had glue extension. The third trial, which is America, which was done here in the States, and was published within the last few years. And actually, the 5-year follow-up was just published 2020. 89 patients of the VCLOS trial, 89 patients were randomized into VENASEAL group and RF group. This trial took only GSVs, and they followed the patients for 5 years. And basically what they found that the VENASEAL closure rate was not inferior to RF. 20% of patients had some kind of phlebitis. Most were mild and treated symptomatically and with non-steroidals. There was no glue extension. And the WAVE study also was published 2017. And the unique thing about this study is the inclusion of bigger veins up to 20 millimeters in diameter, and the occlusion rate was excellent as well. So most of those studies were short to moderate term, and they had limited numbers of patients in them. So in an effort to find the long-term effects of VENASEAL, a European study was published actually 2020, where Dr. Futz and his team looked in a multi-center setting at 2,800 limbs and followed them for 8 years. And basically the 98-month closure rate was great at 96.1%. However, A limitation to this study was it only included patients with mild disease C2 to C3, and there was no control study. What's another interesting thing about this study is the distance from the tip to junction was 2.5 centimeter, but they still ended up with only 0.17% patients with glue extension. Complications of VENASEAL range from post-op pain. Phlebitis usually is limited and responds to symptomatic treatment. Allergic reaction usually is local. It's very rare to have a systematic allergic reaction. Mechanical failure and eGIS, or a glue extension into the deep vein, can happen. This can be classified according to Dr. Gibson in a recently published paper into 4 grades, where grade 1 and 2 is treated symptomatically, grade 3 and 4 is treated with anticoagulation. Caution is recommended with smaller veins, less as 5 millimeter in diameter, because those can be at a higher risk of glue extension. Dr. Almeida published a recent paper where he looked at histology from GSV that was closed with VENASEAL 5 years prior, and he showed that basically the histology shows a status of chronic foreign body response with dense fibrous tissue in the middle of the vein here, surrounded by macrophages and giant cells. There was also granuloma, an inflammatory response in the media extending into the adventitia. Now, how does this chronic foreign body reaction affect the host organ in the long term? I mean, 10 years or 20 years of the procedure, the answer to this question is still unknown. The last one of the non-thermal technologies is the MUCA, and this was first reported for human use in 2009. The mechanical component is a rotating wire that will disrupt the barrier between the sclerosant and the media. And the chemical component is STS or Polidocanol, which will go into the media, cause scarring, fibrosis, and closure of the vein. Speed of the pullback of the catheter is a very important factor, and the recommended speed is 1.5 millimeter per second. The most common reason for failures is actually pulling back fastly. The volume of the sclerosant to be injected depends on the diameter and the size of the vein. Polidocanol and STS has both been used, and both have the same efficacy. It is important to, if you're considering doing phlebectomy with MUCA, that you secure access with the MUCA first, do the phlebectomy, then go back and finish the MUCA to minimize the risk of DVTs. Another important thing is, unlike thermal ablation, where you expect the vein to contract after ablation, in MUCA, the vein will be actually dilated. So it's important to use colored Dopplex to document absence of flow after the procedure. The Maradona study was a randomized control trial published a few years ago, where patients were randomized into MUCA and a REF with a primary endpoint of patient pain relief at 2 weeks and ultrasound success at 1 year. That study showed that patient had marked relief in their pain, no complications. The only thing is 7 patients in the MUCA group had some kind of hyperpigmentation compared to 2 patients in the RF group. And anatomical success rate was inferior in the MUCA group compared to RF. At 1 year, 83.5% of veins were closed at 1 year compared to 94% of the RF, and 80% of veins were closed in the MUCA at the end of 2 years compared to 88.3%. Another important observation from that study was partial recanalization. Early partial recanalizations was connected to future anatomical failures. That study was limited by its size, and they did not include C2 patients because C2 are not covered by insurance carriers in Netherlands, where this study was done. Another study by Dr. Sari, which was published a few years ago, also randomized controlled trial comparing MUCA to RF. The takeout point from that study was, as the vein diameter gets higher, the bigger the vein is, the higher the failure rate with MUCA. Also, that study confirmed our findings from the Maradona study with a closure rate of MUCA being around 82%, which is inferior to RF and laser, which was 100% in that study with a robust p-value. And also that study confirmed our suspicions from the Maradona study about proximal recanalizations. Partial proximal recanalizations at 1 year often predicted total recanalizations in the 2 years that follows. So in conclusion, looking at both technologies. Thermal technologies can be used for bigger veins that had previous thrombophlebitis or been treated before and failed. There is, of course, the risk of nerve damage with thermal techniques. It requires longer follow-up and a longer learning curve, but on the other hand, you don't leave any foreign body behind. The newer non-thermal, non-tumescent technologies has a shorter follow-up, requires shorter follow-up, and they have shorter learning curve. There is less post-operative pain, and usually there's less skin side effects, except with VENASEAL, where you might see a little thrombophlebitis and a little bit of local allergic reaction, but that usually can be managed symptomatically. There is less risk of nerve damage, and non-thermal technologies might be good for below knee GSV and SSVs. Dr. Almeida, in a case report, reported using MUCA treating C6 patients using retrograde axis. Vein diameter is important when considering non-thermals. Smaller veins might not do good with VENASEALs. Huge veins might not be a good candidate for MUCA, and mechanical failures can happen with VENASEALs and MUCA. Other patient considerations that should be looked at is patients with obesity, lymphedema, cost, patient preference, and vein tortuosity. So all of those should be considered, all those factors should be considered when finalizing a treatment plan. The goal is to eliminate axial reflux and contributing tributaries to secure good outcomes and absence of recurrence in the long term. The last 20 years has been an era of thermal technologies, and it seems that in the future, non-thermal technologies will be the focus. With that, I conclude my presentation. My apologies if I've been talking a little bit fast. I was trying to cover all the material in the time frame. So I thank you for your attention, and I welcome your questions.
So Mohamed, that was a phenomenal presentation. That was probably one of the best reviews of the data that I've heard, either from an academic person or a non-academic person. So congratulations, that was really well done. So before we get to the questions, I made an announcement last week that these lectures will now be available for CMEs. If you go to the chat box, I posted the link. You have to go and fill out the survey in order to claim credits at the end of the year. So with that, does anybody have any questions for Dr. Baiou? No, I think that's a sign of a good talk. You covered everything and nobody has any questions for you. So listen, thanks, Mohamed. That was really well done. And do me a favor, Mohamed, could you email me this presentation? Because I want to put it in my files because it was really high quality, very good, very well done.
Yes, sir, I will. Thank you so much.
I'm very proud of you. Good job. Thank you very much. Have a nice weekend, everyone.